Hello and good morning, everyone. Thank you so much for joining us for today's webinar. My name is Jessica Zavala, and it's my pleasure to welcome you on behalf of the Ohio Program for Campus Safety and Mental Health to the webinar, Facilitating Recovery After Trauma Among College Students. And we are very excited to have two experts joining us today with extensive knowledge in post-traumatic stress disorder and trauma. These individuals both have worked with military personnel and veterans, and one of whom is the Margaret Clark Morgan Endowed Chair for the Department of Psychiatry here at NeoMed to facilitate today's discussion. Before I turn it over to our moderator to introduce today's presenter, I do have a few brief announcements to share. First, CME and CE credits will be available. The activity code for today's webinar session is 77FORA. That's 77FORA. This code will expire on tomorrow, November 24th at 12 p.m. So please be on the lookout for information periodically posted via the chat function regarding how to obtain credits. Also, a special thank you to those who participated in the fall campus community chats. It's really our role as a resource dissemination center to ensure we are providing accurate and relevant information related to mental wellness and suicide prevention resources. We ask that you stay tuned for future webinar topics. We are planning to have presentations on managing anxiety and depression, strategies for recognizing and overcoming burnout, and also panel discussion with experts who will discuss using the 8 dimensions of wellness to combat the increase in suicide that is happening amongst African-American young adults. And so just stay tuned for information on that. Also, please be on the lookout for details via our listserv, and we also invite you to visit our website or follow us on social media regarding upcoming chats and our webinar trainings for the spring. Today's webinar will also be interactive. We do encourage you to feel free to post any questions or comments that you may have throughout the presentation in the chat and question and answer functionality. Finally, this webinar will be recorded and the video will be made available for viewing on our YouTube channel. And now I will turn it over to Dr. Welton to introduce our presenter.
Thank you very much, Jessica. My name is Randon Welton, and it's my pleasure to introduce Dr. Craig J Bryan to our talk today. Dr. Bryan is a board-certified clinical psychologist in cognitive behavioral psychology and an internationally recognized expert on suicide prevention, trauma, and resilience. He is the Stress, Trauma, and Resilience Professor of Psychiatry and Behavioral Health at The Ohio State University and the Division Director for Recovery and Resilience. Dr. Bryan's research has been funded by the Department of Defense, National Institutes of Health, and multiple other foundations. He has published over 250 scientific articles and multiple books, including Brief Cognitive Behavior Therapy for Suicide Prevention and Rethinking Suicide, and has received numerous awards and recognitions for his research. And it's my great privilege and pleasure to welcome him today to our seminar. Dr. Bryan.
Thank you so much for the introduction, and thank you as well for inviting me to spend a little time today talking with you all about trauma and suicide risk as well amongst college students. Let me pull up my slides here real quick. Okay, so what I thought I would do today is spend a little bit of time talking about some of the more kind of mental health treatment focused approaches to facilitating recovery. I do want to sort of note maybe like an asterisk from the start that I don't want people to come away from today sort of feeling these are the only ways to facilitate recovery after trauma, but I'll be focusing on one particular approach that has a good deal of scientific evidence to support it. So my disclosures before we get started, I have received multiple grants, consulting arrangements. None of these conflicts or these business relationships are related to any of the topics I'll be talking about today, though. So I want to begin by talking about a case that I treated several years ago, and I actually provide some information about this in one of my new books entitled Rethinking Suicide. And I'm going to name this case, this patient that I treated several years ago, Jenny. So Jenny, when I met with her, she was approximately in her mid to late 20s, and she was referred to us by actually one of her former roommates, family members, who was aware of some of the treatment work that we were doing with PTSD. Now, Jenny had experienced sexual assault while she was a college student during early college. She was raped by another fellow student athlete whom she knew. In the aftermath of her sexual assault, she did report the event, but experienced a significantly unsupportive response from law enforcement, university administrators, as well as her family and friends. And her experience and sort of description of what that was like was a lot of skepticism about what happened, a lot of traditional victim blaming types of questions like, what were you wearing? Are you really sure it wasn't consensual? Those sorts of things. The response to her reported rape was not particularly supportive. And she described finding herself in this, difficult and challenging position because as a student athlete herself, she was afraid that if she transferred to a different university, she would not necessarily receive a scholarship for athletics, and which would, in essence, render college unaffordable for her. She didn't necessarily want to stay at her current college, however, because she would be repeatedly exposed to reminders of the rape as well as her assailant. She struggled with this decision for a long time, but ultimately decided to remain enrolled at the college where this happened because her mental calculation was completing my education, getting a degree is more important than my well-being in the short term. But nonetheless, she struggled considerably throughout the remainder of her college, academically, socially, and in retrospect, of course, much of her struggles were related to the onset of trauma-related symptoms, sleep disturbance, unwanted memories and dreams about the sexual assault, social isolation, a lot of negative self-statements, blaming of herself, feeling isolated from others, things like that. Now, once she graduated from college, she moved multiple times. She would move across the country, find a job, but then after a few months kind of pick up and move again, and had done this multiple times during the course of the years after college. She also struggled to maintain relationships, especially romantic relationships, finding that she had difficulties trusting others. And in some cases, she would engage in relationships that were not necessarily positive or supportive. Specifically, she engaged and initiated relationships with men who were married or were in other committed relationships. And so kind of recognized that perhaps this was not necessarily the most satisfying relationship status to have. She sought out mental health treatment multiple times and was in and out of therapy, different types of therapies for several years. She ultimately stopped mental health treatment, however, because one of her therapists, a counselor, during one of their sessions, made a comment along the lines of, well, you shouldn't have stayed at that school. And the implication with that was that the problems that Jenny was experiencing were her fault. If she had transferred, if she had left the college, then she would not have sort of re-exposed or re-traumatized herself multiple times. So Jenny understandably, I think it reasonably took that as blaming her for what had happened, and stopped mental health treatment at that point. Afterwards, for several years, she continued to decline, continued to experience worsening of symptoms. She started to become increasingly hopeless and started to experience the onset of suicidal ideation, thinking to herself that, I could just kill myself. That'll end all of this. So, as I alluded to before, it was actually one of her former roommates who remained in contact with her, was concerned about Jenny and suggested, let's try something else. And so her former roommate's parents actually knew us, reached out to us and said, could we potentially have Jenny engage in trauma-focused therapy through one of the programs that we were doing at the time? We were piloting intensive daily sessions of trauma-focused therapy compressed during a 2-week window of time to shorten the length of trauma therapy. So we agreed to have Jenny enroll in one of our programs if she so selected, and she ultimately did. At the outset of therapy, when I first met with her, she expressed a lot of skepticism, said that, I've been in a lot of treatment, a lot of therapy, nothing has helped up until this point. And so I think this is just, kind of how my life is going to be. But I figured I would travel across the country, come to this program, because I figured I don't really have that much to lose. And if I don't feel better after this, I could just kill myself. And so this is kind of my last stop. So we started treatment on kind of risky grounds, so to speak. We engaged in 2 weeks of cognitive processing therapy. We met for 1 hour every single day for 2 consecutive weeks. And over the course of therapy, she experienced a significant reduction in PTSD symptoms, resolution of suicidal ideation. And as of a couple of years ago, when I last received an update from her, which was a few years post-treatment, she was still doing very well and was contemplating some new changes, moving again. Although this time what she said was, I'm moving not because I'm trying to run away from my problems. I'm moving this time because I want to live someplace that I want to live, and I want to choose my life and my community as opposed to always running away from lives and communities. And so I start there to kind of highlight a story here for Jenny, who experienced trauma during college and was not able to experience relief from PTSD for many years. And in many ways, I think Jenny's case highlights a great example of how much earlier in the time course of her post-trauma life, there could have potentially been an opportunity to intervene and perhaps head off or alter the trajectory to save her many years of suffering and difficulty. And so one of the concerns, though, I think that many of us run into, and I certainly have encountered this as a clinical psychologist myself, is that there is this pervasive belief or myth, I would argue, within the mental health disciplines that trauma-focused therapies are unsafe with suicidal patients. There's even many who would argue that trauma-focused therapies are unsafe, period. That the concerns are that it re-traumatizes patients, it's too difficult, too upsetting for them. And then those concerns are magnified if you add on top of it someone who is actively suicidal. Now, these concerns, aren't, something that's recent. We can actually look at, expert consensus statements about this practice guidelines. And for many decades, actually, there have been recommendations against PTSD-focused treatments when somebody is acutely suicidal. Um, and in some cases, like for instance, with prolonged exposure therapy, one particular type of trauma-focused therapy, acute suicide risk has been identified as a possible contraindication for therapy. And that's sort of interesting because many of the procedures that are used in trauma-focused therapies, like breathing exercises, cognitive restructuring, exposure-based interventions, are actually first-line treatments for depression and suicide risk. And so the procedures that are used in trauma-focused therapies are also used in suicide-focused therapies and mood disorder-focused therapies and are considered safe and effective. But for whatever reason, those same exact procedures are considered dangerous if somebody has a diagnosis of PTSD. And so the past decade or so, I've really kind of reflected, like, where did this come from? Like because it seems sort of contradictory in many ways that the things that we do within treatments to prevent suicidal behaviors and that work to prevent suicidal behaviors are considered harmful or expected to worsen suicide risk simply because somebody has been diagnosed with a different condition. And I think there are three sort of sources of this myth. The first of which is that there's well-documented evidence that training amongst mental health professionals is not sufficient when it comes to suicide risk management. The same is true for treating PTSD as well. There's a report, now it's about 8 or 9 years old, from the American Association of Suicidology showing that fewer than half of mental health professionals receive training in suicide risk management and treatment while in graduate school or medical school or at some point within their professional training pipeline. We also know that the typical clinician attends only a handful of CE hours over the course of their entire career focused on suicide risk management. And then I think part of the issue is that suicide risk training, as it's typically delivered, often emphasizes risk assessment as opposed to treatment. And so we in essence aren't really teaching people what they need to be doing and how to adequately work with people presenting with suicide risk. I think another related problem is that suicidal individuals are routinely excluded from clinical trials. And so, in essence, during that initial assessment period, people come in, they report active suicidal ideation or something like that. And then, in essence, the researchers say, well, no, we're not going to include you because it's too dangerous or it's too high risk. And so what ends up happening is we don't really fully understand or know a lot about how to effectively treat suicidal individuals because, in essence, we're saying that you can't get into the studies. I've even run into this myself just within the past month or two when one of our studies where we're enrolling very high risk, acutely suicidal patients who have recently attempted suicide or have very high levels of intent. And in essence, we know that this is a high-risk group and that some of them are going to attempt suicide during the course of treatment and during the course of the study. And we had to have a meeting with our IRB recently because they, in essence, were saying, well, you've had a bunch of participants who are attempting suicide. Perhaps you should take a lower risk group because it's really dangerous. And we really had to kind of provide the counterpoint of, yeah, I know that they're high risk. That's the point. Nobody else is willing to include these types of individuals in their studies. And so they are at very high risk of dying. And we are trying to figure out how to prevent that from happening. And so it's kind of interesting how the profession as a whole is often sort of organized and geared around this risk-averse mindset that, in essence, makes it hard for us to really effectively understand and help people with trauma as well as with elevated suicide risk. And then I think a third source of this myth comes from just misunderstandings about PTSD and trauma-focused therapies. There's this pervasive perspective of PTSD as a chronic or uncurable condition. I've also found over the years that there is this, especially in some subgroups of the discipline, this extreme reverence for so-called triggers, and that triggers are potentially problematic and should be avoided because they activate or lead to intensification of emotional distress. And so as a result, if there is something that might potentially be upsetting to a person who has experienced trauma, we should take steps to avoid or to remove them from those exposures, which unfortunately inadvertently will actually reinforce and sustain PTSD as opposed to facilitating recovery afterwards. So we have a lot of, I think, issues kind of driving to these concerns about treating people who have experienced trauma, especially if they're higher risk. And I think the consequence, of course, is that a lot of people who are suffering and struggling are not receiving treatments and interventions that could actually be quite effective for overcoming that suffering. And I've been on college campuses now for multiple years and worked with counseling centers and other groups. And I think this is an especially key problem for the college age, transition age adult. Well, what does the research tell us about this issue? Well, first off, I want to highlight, and we'll actually briefly talk about today, that there are multiple studies showing that suicidal ideation actually decreases on average in trauma-focused therapies. We also are seeing now in studies that suicidal behaviors, worsening of pre-existing suicidal ideation, and new onset suicidal ideation are actually quite rare in trauma therapies. And when these types of events happen, they are comparable to the rates that we see in non-trauma therapies. And so that's kind of a different way of saying that when suicidal behaviors occur, if there's worsening of suicidal ideation or if there's new onset ideation, it does not necessarily seem to be attributable directly to the treatment itself or to the condition. It seems to be something that is observed in mental health treatments amongst mental health treatment seeking adults in general. And so I wanted to highlight a handful of studies that back up this claim. The first of which was published by Jamie Gratis not quite a decade ago. They conducted a secondary analysis of a study conducted by Patricia Rezick that looked at prolonged exposure and cognitive processing therapy, which are two trauma-focused therapies, and looked at what were the rates or the probabilities of patients endorsing suicidal ideation at different time points. And on that top right figure there, what we see is that in both of the trauma-focused therapies, the probability of experiencing suicidal ideation dropped significantly from pre-treatment to post-treatment and then continued to decline gradually over time. The LTFU at the bottom of that graph stands for long-term follow-up. So they actually tracked participants for up to a decade after treatment and found that there were these long-term anti-suicide effects associated with trauma therapy. I collaborated with some military researchers and conducted a very similar study looking at suicidal ideation amongst service members who were participating in group therapy, group cognitive processing therapy, as compared to present-centered therapy, which is a non-trauma focused therapy. And what we see is that here again, the severity of suicidal ideation significantly reduced on a week-to-week basis from baseline to post-treatment. There was a spike at the 6-month follow-up, but then suicidal ideation resolved again by 12 months post-treatment. Similar data have been seen in studies investigating prolonged exposure using a masked intensive format as compared to weekly sessions of prolonged exposure. And what's kind of interesting here is that on the left-hand side, from baseline to post-treatment, we again see a reduction in the severity of suicidal ideation. And then from post-treatment to 6 months, we start to see the recurrence of suicidal ideation. So there's something about the 6-month follow-up that there is oftentimes a recurrence of suicidal ideation. I'm going to talk a little bit more about what we're doing now to figure out how to sort of squash that bump at 6 months post-treatment. And then most recently, there's a new systematic review in press at the Journal of Traumatic Stress by David Rozek and colleagues that looked at 23 published studies across different populations, age groups, and treatments, and found that change in suicidal ideation actually goes down. Ideation resolves during trauma therapy, and the greatest amount of evidence for this is seen in prolonged exposure and cognitive processing therapy, which are the two kind of strongest or the most well-supported trauma therapies that are available. And I wanted to call your attention to one study that was specific to college students. So this was done by Charity Wilkinson and colleagues at Rutgers University and the University College Counseling Center, finding the exact same patterns where we see these significant reductions in PTSD symptom severity as well as depression severity. And they looked at suicidal ideation as well and found reductions in suicidal ideation amongst college students who received trauma-focused therapies. And this because the treatment protocols are typically 10 to 12 outpatient sessions. They're very practical and can fit within the typical college counseling center time-limited treatment models that are fairly commonly used. And so what does all this mean? I want to highlight that the trauma-focused therapies, cognitive processing therapy in particular, which is the treatment that I use, have been trained in and use most often, has been found to be incredibly effective for treating PTSD and reducing suicide risk in a lot of different samples and a lot of different groups. And I include here sort of this table to help kind of convey that these are very, very robust findings. So for instance, if we look at how the treatment is delivered, we've seen that whether it's delivered as an individual therapy or as a group therapy, it could be delivered, once per week, or it could be delivered once per day for 2 weeks. We see significant reductions in PTSD and suicide risk. We've seen that the treatments work when they're delivered by mental health therapists, but also interestingly by community members or by peers. So there's been research looking at these treatments, for instance, like in the Democratic Republic of the Congo, where the researchers trained community leaders to deliver trauma-focused therapies in the midst of a pretty brutal civil war, and found that when these trained community leaders delivered these trauma therapies, it led to significant reductions in PTSD symptomatology, particularly amongst women and children who are oftentimes the trauma was rape by a lot of the insurgent forces who would come into villages, kind of burn the place down, kill a bunch of people, and then oftentimes rape the women and children. We've also seen that these trauma therapies work when you deliver it face-to-face in person, when you deliver it online. You can do it on the telephone. There's even now newer research showing that it can be delivered via smartphone app. It can be delivered on an outpatient basis. It can be delivered residential. It can be delivered inpatient. It can be delivered in the recipient's native language, whether that's English. We've done this in Khmer, Iranian, German, Congolese, French, Japanese, or we've also tested it when the treatment's delivered via an interpreter. So as an example, Tracy Clemens did a study with adolescents in Cambodia who had been rescued from the commercial sex trade industry and delivered group trauma-focused therapies through an interpreter who was able to deliver everything in the Khmer language. Everything was also translated into the native language. We've also seen that these treatments work for men and for women, veterans and civilians. It's worked for those who've experienced war trauma, sexual violence, child abuse, motor vehicle accidents, those with a single trauma, those with repeated multiple traumas over their lives, and also with comorbid conditions or problems, including substance use, suicidality, depression. We've seen it works for people across the entire lifespan, adults, adolescents, and children. And then I mentioned before in different languages, and it's even been adapted and delivered to populations who are illiterate using verbal as well as pictorial depictions of treatment concepts. And so when we think of trauma-focused therapies, then we've got an incredible amount of evidence that they are highly effective. And so it's interesting then when I do hear from different groups, different audiences like this, these treatments won't work for this particular population. It's not been tested, or it won't necessarily work for college students, for example. I find that curious because these treatments have been tested so many times in so many different ways to include college students that it just doesn't make sense as to why we would withhold these particular therapies from our clients and our consumers. I think, something else that I'm asked about a lot is, well, maybe there are other treatment modalities that work as well. Maybe we shouldn't necessarily focus only on trauma-focused therapies because there are lots and lots of different therapies and treatments that have been proposed for the treatment of PTSD. And I'd put here just, a short list. This certainly is not all-inclusive, but it's the treatments that I would say that I'm asked about most frequently to comment on. And so I wanted to kind of break down very briefly kind of the evidence supporting many of these different types of treatments. And what I have found to be very helpful and informative is to approach this from like an investment perspective or a return of investment. You might be kind of wondering about that, but maybe if you kind of reflect upon like if you, when you were selecting maybe like your retirement benefits, your 401k or something like that, oftentimes we get these like tables about how different like retirement or investment portfolios perform during different time frames and risks. And there are all these like numbers and things like that to help us to make decisions. And so we can oftentimes come up with similar decision-making algorithms, I think, when it comes to different forms of therapies and treatments. And so I've included here several sort of questions that we might ask about various treatment modalities to kind of think about what might be most effective for the population that we're serving, even if there might only be, say, like a handful of studies that are specific to our population out of the entirety of research base, we can still nonetheless extrapolate from all of the data to make some reasonable assumptions about how this would work for the population that we're most interested in. So today, of course, talking about college students. Right? And so if we look at the first question, like how many people feel better, what percentage of people who received the treatment report improvement? What's interesting is we see that trauma therapies, over 80% of those who receive prolonged exposure or cognitive processing therapy will report some form of improvement. Might not be large improvements, but they're definitely better afterwards than they were at the beginning. Now compare that to some other treatment approaches. We have like antidepressants. Not as many people benefit from antidepressants. There's some newer novel treatments. I'll highlight a couple of those like stellate ganglion block and transcranial magnetic stimulation, which about half will report some benefit. And then there are lots of what I classify as experimental treatments that have not actually been studied. And we don't actually know how many people get better with that. We can also ask the question, well, how much better do people get? So, I mean, a little bit of improvement, that's great. But it'd be nice if there was large improvements. And so that's where, again, we see the greatest benefit from trauma therapies. Over half of people who receive a trauma therapy no longer have PTSD afterwards. They go into remission. And the data available thus far suggests that when PTSD is treated to remission, it doesn't really seem to have recurrence or relapse. Now, the trauma therapies, how long do they take? Typically, 2 weeks, maybe up to 3 months. The risks associated with those therapies include things such as mild discomfort. There is, for about a quarter of patients who receive trauma therapy early in the first 2 to 3 sessions, some will experience a slight worsening of their anxiety symptoms before things start to improve. And then we can also ask, how do we know this? Well, the trauma therapies are unique in that we have decades of research backing up these particular approaches, as compared to on the far right-hand side. A lot of times the experimental treatments are mostly testimonials or marketing information from the companies that develop and sell the treatments. And so when we kind of look at all of these sort of different trauma therapy options, when I'm working with patients or I'm educating individuals asking about, well, what type of treatment should I receive, or does this particular treatment work? I like to use this approach and say that, all things being equal, you should place your bet on a trauma therapy, because we can't guarantee that someone will benefit from a treatment. We don't know in advance who's going to get better and who's not. We haven't, developed that technology yet. But again, from that investment angle, this is like your surest bet. This is where the biggest payoff or reward is likely to come. And so if we're going to place our time, effort, and resources anywhere, trauma therapies are probably where we should be focusing a lot of those resources. And so in light of that, I would argue that the strongest signal for facilitating recovery after trauma in all populations, to include college students, are the trauma-focused therapies. Now, we do have some evidence for things like TMS or stellate ganglion block. TMS is a newer treatment, involves coming into a specialty clinic every day for anywhere from like 4 to 6 weeks, and basically kind of sitting in a chair, and they kind of position these magnets around your head. And the idea is that through magnetic stimulation of certain brain regions, it can alter brain functioning. There's some preliminary evidence that this might be helpful for PTSD. It's highly effective for depression. So there's better data for depression. And right now the research is still kind of emerging for PTSD. And then there's stellate ganglion block. SGB is also kind of a new somatic treatment that involves an injection of an anesthetic into the stellate ganglion region of the neck. This is a treatment that actually has been used for years for chronic pain management, and it's been shown to reduce anxiety symptoms. And so there are a handful of studies, mostly in military populations. I think that's one thing to note thus far, is that there are small reductions in PTSD symptoms that last for a few months after these injections. So some possible signal there, more research to be done for sure. There's a lot of excitement in the past few months about psychedelic assisted therapies like with psilocybin, MDMA, things like that. I would say that the data thus far are too early to tell. It's a little unclear. The trials that have been conducted, a handful of them are really good studies. But I would say that we might want to hedge our bets just yet. It'd be better if we had some more studies before we really kind of go all in and really fully endorse this. I will say another issue that might be relevant for those working with college students, because the psychedelics are also available through non-regulated or unregulated modalities. I have encountered some who will say, well, I'll just go get some ecstasy or MDMA off the street or through the black market, in essence, or the same with other hallucinogens. And the big thing that I caution people against is that the purity, the dosing, other potential additives are unknown through those channels. And so there's a heightened risk for adverse events when these types of substances are ingested or consumed outside the more highly, tightly controlled clinical medical setting. There's a lot of treatments that we also don't really know anything about, although my read of things that they probably are minimally effective. They maybe aren't going to actually be all that helpful. I am aware of there was a ketamine trial that was just recently completed. Again, another treatment that's getting a lot of excitement right now. And the results of this recent trial suggest that actually it did not do better than placebo for reducing PTSD. And so some newer developments there that maybe that particular treatment option isn't going to be panning out too well. I get a lot of questions about like service animals in particular. I don't have a lot of time to talk about it, but I will just acknowledge I'm kind of skeptical. I don't think that it necessarily helps all that much with PTSD. And I do have some concerns that maybe in some cases it actually sustains PTSD and anxiety for some people. And then of course, there's these other treatments. These are just two examples that I get asked about: essential oils, dietary supplements, things like that. These are probably noise. I don't think there's really anything to them. And I think it just sort of clouds in the field and sort of gets in the way of good treatment, to be perfectly honest. I can develop a similar list of treatments and strategies for preventing suicide attempts. One limitation, I think, of the suicide research is that it's a lot newer. We have like 30, 40 years of research on trauma-focused therapies, but I think it's only been within the past decade or two that we have pretty solid research focused on treating suicide risk. Where we are seeing a definite strong signal are with these interventions here. Some of these are probably familiar to you, like dialectical behavior therapy, CBT for suicide prevention. That's a treatment approach that I've been focusing on a lot in my research, doing a lot around means restriction as well, especially firearm access. But I think there's a lot of mileage that can come out of a medication-focused means restriction as well, which I think is highly applicable in college students. There's also crisis response and safety planning is getting some good data in support. That's actually an intervention. We've started to do a lot of trainings for non-healthcare professionals, like residential hall assistants, student leaders, professors, administrators, a staff within different offices, like student life offices that work with minoritized or disadvantaged students, as a way to help out with immediate short-term crisis response while we try to get students connected to higher levels of care or more formal treatment options. And then there's caring context, kind of an interesting intervention, kind of low intensity. It's been shown these are things like sending postcards or even text messages now, showing that periodic expressions of concern and sometimes a text message as simple as like, we're thinking about you, has actually been shown to reduce suicide attempts by about 50% or more. We've got some newer data emerging, but new treatments, not a whole lot available yet. And then I think ketamine, again, is a little bit too early to tell. So I know that I'm running out of time. Basically, I'll share with you all the last slides. I won't go through them in detail, but they have it available for you. These are just the results of some of the clinical trials looking at suicide-focused interventions and showing that we can basically prevent suicide attempts by about 60% or more in some cases, even with very simple strategies like this, the crisis response plan, where it's just writing like checklists on an index card. And now there's smartphone options. We're actually testing smartphone iterations of this, which I think is going to be very, very popular and highly used amongst transition age adults. So to end where we started, I propose that there was this myth that trauma-focused therapies are unsafe with suicidal patients, that we cannot effectively treat PTSD and suicide risk. And I would argue that the sources of this myth are not reliable. We can actually effectively treat PTSD and suicide risk. And we now have new clinical recommendations available for that have been published, where we're actually now starting to do integrated therapies and treatments where we're treating PTSD and suicide risk concurrently. And we're starting to get very, very good results. And so what I think all this means is that for a long time, we have withheld, I think, highly effective treatments from college students and others who have experienced trauma. And we have the data now to suggest and indicate that we don't need to do that. We should be aggressively treating PTSD and suicide risk, because treatment of PTSD is suicide prevention. And I think early in the adult development during college is a key moment for us to get in and to help people to recover from traumatic experiences, because I think it can alter the trajectory of their life course for many years. So I'll stop there, and I look forward to questions and discussion that people might have.
All right, great. Well, thank you very much, Dr. Bryan. Lots of questions. We will get through as many as we can. In some of your slides showing suicide rates following treatment, there was a steady decline during treatment and then a spike that came several months later. Any thoughts as to where that spike came from?
Yeah, we have a few ideas. One, I think, the leading hypothesis is that we see after treatment has completed, there tends to be a rebound effect for lots of symptoms. This is true of all of therapies. And we think what happens is that once a person exits or wraps up the treatment process, then they're sort of on their own in some respects. And so there can be a recurrence of some symptoms. So now what we've started to do with this is we educate people on that process, especially as we get close to the termination phase of treatment, to say you might experience a recurrence of anxiety. You might have dreams that happen every once in a while, and here's what to do about it. So focusing on relapse prevention seems to be key. And some of our newer data, we have a clinical trial ongoing right now, for instance, at OSU, where we've integrated crisis response planning into trauma-focused therapies. And it appears as though we have been able to suppress that 6-month bounce by basically prepping people for that process and providing them with a self-management tool that has been proven to significantly reduce suicidal ideation. So more to come on that. But my recommendation at this point is integrate crisis response planning, but also start to explicitly integrate relapse prevention into the end of trauma-focused therapies to help mitigate that sort of natural change process.
Great, thank you. Another question, have these therapies been adapted when working with Black students or other students of color, including those from LGBTQ plus community, when the trauma that they experience might be from the institution as a result of their specific identities?
Yeah, so I can say that they have been tested with with adults and children from a range of racial, ethnic backgrounds. I don't know if it's gone so far as like testing for institutional forms of betrayal or like, now what I do know is that we have tested it with sort of betrayal forms of trauma in general. And my work, which is mostly with military personnel and veterans, we see a lot of institutional betrayal there as well. And so we have been able to use it. So I would say I don't know if it's like college institutional betrayal related to identity, but that I will say that in our work, we have encountered those dynamics and those issues. And the treatments do seem to help with those forms of traumas as well.
Okay, thank you. I noticed, and as you're very well aware, in Ohio, medical marijuana is approved for the treatment of PTSD. That was not on your list. Where would you put medical marijuana as an effective treatment for PTSD? Is it well-established, experimental?
Yeah. So it probably experimental because we don't really have a lot of data on it. My sense is that the way that we approach this with like the patients coming and seeking out treatment, because we have plenty who are using marijuana to varying capacities and degrees. What we do is we engage them in a conversation before we start treatment and say, to understand what is the role that marijuana or any substance, is true of any substance, plays within their illness, within their diagnosis, and then what are their goals specific to substance use. So what we find is that there are some who say, yeah, I use to cope. It's an avoidance strategy, and I don't necessarily want to be getting high all the time, but nothing else works. And so we can very effectively treat those individuals, and as their trauma improves, they tend to reduce their marijuana usage. Then there's another group who basically say, I have no intention of cutting back. I'm going to get high every day. What we typically do is we just say, I don't know that this is going to be the right treatment for you, because it's your choice. If that is your preferred, coping strategy, treatment option, then that's fine. That's okay with us. But it just doesn't really seem to be conducive to a trauma-focused therapy. And so it wouldn't make sense for us to engage in this treatment if that's your preference for your healthcare. So that's kind of how I would recommend you approach that conversation with your patients.
Right. Thank you. You had emphasized trauma-focused psychotherapy. So there's a question about what qualifies as a trauma-focused psychotherapy. If you're doing general CBT, but often deal with thoughts related to trauma, if you're doing solution-focused, and again, dealing with the issues about trauma, EMDR, do those things count as trauma-focused?
Yeah, that's a great question. Sort of the classic, the protocols that are typically included under trauma-focused therapies are prolonged exposure, cognitive processing therapy, and then there is this kind of more generic trauma-focused CBT. So there's debate over EMDR. So some people classify it as a trauma-focused therapy. I would classify it as a trauma-focused therapy. Others don't. And I've found that some EMDR proponents say, no, it's not a trauma-focused therapy. And I think it's because their perception is that EMDR is qualitatively distinct or different from the other trauma-focused therapies. So I don't know. I guess it kind of depends on just your perspective of it. But EMDR, does have good empirical support for it. I think the reason it's controversial is because the purported mechanisms, the reasons why it works, haven't necessarily been supported scientifically, but the outcomes are comparable to what we see with exposure therapy and cognitive processing therapy.
Right. You had talked about treatment, you had talked about suicide prevention. Are there any other specific strategies or coping mechanisms or support systems to help, especially student veterans with PTSD, kind of succeed academically? In addition to getting them treatment, which we understand is pivotal, are there other kind of supports that are evidence-based or evidence-supported?
Yeah. I think the other thing that we're starting to recognize is that PTSD and suicide risk, and arguably all mental health conditions, there is this very strong social component. And so we have found, for instance, in our work with veterans, the trauma therapies are highly effective, but oftentimes, when there is a lack of response, or sometimes there's a, recurrence of symptoms, what we found is that oftentimes those are individuals who live and work in unsupportive environments. So the family members, friends, coworkers, peers, walk on eggshells around them, maybe reinforce trauma-related beliefs like, you can't really handle your emotions. Are you going to lose your cool? And so I think if we kind of generalize that to the college campus context, what I found, in the past is that oftentimes there's a lot of misunderstandings of veterans, that there are these sort of cultural rifts, especially sometimes with faculty members, who maybe have different, kind of political perspectives than, or particularly as it relates to military operations, military action, things like that. And so being able to educate, I think, the campus community, it's not evidence-based in the sense that I'm not aware of like any randomized controlled trials, but they're strongly correlated with ideal academic outcomes amongst college students. I think it's very similar to like the question before about how, you know, a lack of consideration or respect for a person's identity, whether race, sexuality, gender. I think the same is true for military service veterans. And where we have seen a lot of student veterans struggling is that they feel nobody understands me. They just think I went and like killed a bunch of people overseas. They ask inappropriate questions. And so I've found it useful in my own work to kind of conceptualize military service from a multicultural perspective, because it does sort of reflect a lived experience that influences a person's value system, their worldview, things like that.
Well, I think I have time for one quick last question, and along that very line, for those counselors, for the therapists out there who don't have that military background, don't have a lot of experience dealing with veterans, and yet are seeing student veterans in their clinic, are there good places for them to go to get resources to understand it better, either resources for themselves or resources for their clients?
Yeah, there is. You know, the Center for Deployment Psychology has a lot of great online trainings, especially, and a lot of them are free. I know Ohio is a star behavioral health state as well that offers trainings for mental health providers on military veteran issues. But I would say the last thing to consider is that, you know, I hear particularly from like civilian clinicians of like, well, I don't understand the culture. And you can learn these things. You can get exposure to that, and I think that's great. But I want to remind people as well that I think a big part of effective care in the profession is cultural humility, and just recognizing and being okay with not understanding the life experience of every client or every patient. And so when it comes to veterans, don't get too anxious that I don't fully understand the culture, because at our core, we're all humans. And I think we can connect with veterans or anyone with a background that isn't necessarily shared by us. And I think as long as we own that and say, you're right, I don't understand your experience, would you be willing to help me understand? I think that's the core of competency that, you know, is going to be really critical. And I don't know that you can learn that in any like webinars or anything like that. And so don't get too stuck on just like the content of like how the military works. Also kind of remember these more like humanistic aspects of the profession that we're engaged in.
Thank you. I would love to keep asking more questions, but I see Ms. Zavala has clicked on, which means it's about time for us to wrap up. Thank you so much. I will personally thank you. I think this was a wonderful talk.
Absolutely. Dr. Bryan and Dr. Walton, thank you both for lending your expertise to Ohio's campus stakeholders today for the webinar. Excellent presentation, very informative information that was shared. And I just want to reiterate to those who are still on, thank you again for participating today. The slides will be forwarded to you all, as well as this video presentation will be uploaded to the Ohio Program for Campus Safety and Mental Health YouTube channel at a later date. So again, we thank you for joining us today. And one last time, if you are interested in obtaining CEU CME credits, that code is 77 FORA. That's 77 FORA. And I believe Abby will post that information inside of the chat one last time. Again, Dr. Bryan, Dr. Weldon, this was very, very informative. Awesome presentation. Thank you both again for your time today for joining us.
Thank you for having me.
Thank you.
Yeah, thank you.